All right, good evening. I'm going to call the special meeting to order, the presentation of the ambulance service options for the city of New Prague. This is a special meeting. North Memorial will be presenting, North Memorial Health Ambulance will be presenting here at 7:30, and then Mayo Clinic Health, or Mayo Clinic Ambulance will be presenting at 8:15. The meeting is not going to be open to the public for public comment. This meeting is just for the council to obtain information. The decision of that council, or of the council, will be made at the next council meeting, and that's where we'll take public comment if people want to speak. So, with that, I'm going to turn it over to North Memorial.
All right. Well, thank you. Thanks for having us, both some of the speakers and some of the rest of our team. Thank you for coming and showing up tonight too. Appreciate this opportunity. Going to go ahead and, real quick, introduce some of the other speakers so we don't have to do that. Scott Sampe, I'm the Vice President and Chief of North Memorial Health Ambulance Service. Also with us tonight is Dr. Pete Tangy. He's our Medical Director. And our Regional Director is Rick Wagner. And the Regional Manager here is Terry Nelson.
Hi.
So on behalf of us, thanks for having us, and we'll go ahead and proceed. I think you have some of the written materials, and
yes, basically
we're going to summarize it.
Sure.
We're not going to drag this out all night and bore you with details, but and certainly when we get to the questions, hopefully we can answer everything you need to know.
Thanks.
All right, so North Memorial, we're one of the largest ambulance services owned by a hospital in the country. We may actually be the largest when you look at both our ambulance and helicopter and all the community paramedic and all the things we do. Our service started a little over 60 years ago as an ambulance service. We continue to do our grounds, our biggest area of transport, where we do wheelchair vans. That's mostly taking people home from hospitals or doctor's office appointments, as well as basic life support. We do that in some of our areas, similar kind of work as the wheelchair vans. We also do advanced life support, and that's mostly what we do here in New Prague. Have a paramedic on board to provide, advanced life support for people, both as 911 calls as well as transfers out of a hospital. And then critical care. Some of our units are prepared. They can go by ground for critical care patients, just like they do on the helicopter, but by ground. And then we have air care, which is our air medical program, and community paramedicine, which some of those folks are here tonight in the audience. I guess I should mention a few of our mission. Our mission really is a lot about customer. At North, we believe, instead of calling people patients, they're our customer. People often have a choice, just like you have a choice tonight, to determine who's going to serve your community. A lot of our people have choices, so that's why we call them our customers. Other things besides our mission, value, and vision is safety culture. Safety is very big for us. We continue to expand our safety division. And newer to us, we put a lot of attention to diversity and equity. So when you look at North, we're very big. We're about the size, cover about the size of the state of Massachusetts. 800 plus employees, 110 ambulances. We have 20 bases with about 30 different locations we sit at. Some of these bases have multiple locations outside of the base where they sit. So even though there's 20 bases, really 30 locations altogether. We have 7 helicopter bases with 9 helicopters serving those. 2 of those are backup. And this past year, just some quick statistics for our overall service. We had 100 plus requests for service. Our air and ground did 98,000 transports of customers. So, and our community paramedicine worked with 6,000 customers. So very busy service. There we go. One of the things I wanted to talk about. So we're talking a lot about mostly the ground service tonight. We'll talk a little bit about our community paramedicine. And I did mention we have an air service. Certainly the air service comes here often too. But one of the things we rarely talk about, and certainly is what makes us such a good service, is all the background support we get. When you look at the slide here, we have 2 dispatch centers that just opened this year. We have our, and we call that Northcom. The first one is in our Brooklyn Center, our main headquarters where we're stationed, and it's been there for years. And they do mostly 911 calls. and some other, once in a while they'll do some transfer stuff. We opened up a second dispatch center down, a little farther down the road, closer to the hospital. The big reason for that is we wanted to have two centers, like anything. If being where we're 911, if we get something cut, a cable cut or whatever, and that center goes down, well, what happens in the meantime? Both centers are able to pick up the volume of the other center immediately without any interruption. We're the first in the state to do that, actually, this year, as far as EMS. And the other one down near in Robbinsdale does both air care and as well as some other air operations that we help dispatch. They do some of our ground transfers also. We have a tech team. When you have such a service, there's more than just IT needs. Mm-hmm. We have radios, the computers. We have a computer in the front of an ambulance, or get us places and show the dispatch where we're going. We have a computer in the back of the ambulance, for the team to do their patient care record. So they take care of all those kind of things, as well as equip our ambulance to do all those kind of things. Fleet maintenance. We have ground fleet maintenance in 2 locations, north and south, and we have air fleet maintenance, both north and south, same thing, so that we can get those different vehicles to the closest center to get them fixed. We have newly emergency services and community relationship specialists that visit hospitals and emergency services to make sure they're out there and they know the needs of the community, and we're making sure we're doing things that are good. And if not, we want to fix them right away. We also have our own ambulance billing service, which is important so that when someone has a question and they call, they know someone that's very familiar about their bill and not some buried in some hospital billing system where they're not real familiar with it. We have our own, just to go around the bottom of it, finance and materials management. We have a safety department, I think I mentioned a little earlier. It's very robust. We're just, in the next couple of weeks, we have a new person coming in to run that department. And he's actually on the aviation side, and he just won the award a month ago for the Aviation Award for HAI, which is a worldwide service for helicopters, and he's the top safety person of the year. So he's going to be working for us in 2 weeks. And then Pete does a lot with our quality and education, all the training they do constantly, and he'll talk about that, as well as medical direction. So Pete, do you want to take over at this point?
Thanks, Scott. Mayor, council members, nice to meet you all. My name is Pete Tangian. I'm the Chief Medical Director for our ambulance service.
Okay.
And really appreciate being able to come out and talk to you all tonight. Like Scott was talking about, it's a lot about the support services, and this is one of my main roles, is to support our clinicians doing the work that they're doing. And I'm fortunate I get to work with officially the oldest medical director in the state as of a couple days ago, Dr. Lilja, and then I'm working with I think the second newest medical director, EMS physician in the state, Zach Finn. So the team of us are out, and very important to us is that we're operational medical directors, meaning we're involved day to day with the operations. We don't just come in and sign papers. The medics, we're working with our medics and EMTs on a daily basis. And for us, what we really are driving is this idea of excellence. And what that means for us is we want to continue to do a very good job and also continually look for ways that we can improve. So I have a great job because we have all these, we have access to all the modern tools for airway management, cardiac care, different medications that we have access to. So it's really a fun job for me because we've empowered our paramedics to solve problems, both through our education and through the equipment and support that we give them, that support that Scott was just talking about. We're also lucky in that we provide direction for 100 and plus different first responder agencies, which include police and fire and some industry. So it's we have a really nice breadth of responsibility and opportunities to work. We have our clinical excellence verified by these accreditation groups, which include CAS and DNV. But what we really are trying to do is make that quality sense externally validated, but really what we want is the clinicians to have a sense of what that means. What does excellent care mean? And that ability to take a guideline, which is what our best directions are, but then apply that to an individual situation. So that knowledge of the guidelines, but more important, that support to adapt that to an individual is really primary to what we're talking about. And so having that push towards excellence really helps, and we want to see that translated in the care that we're providing. And that goes from just somebody who has a very minor medical issue, but they don't know where else to go to, all the way up to that person with the most serious critical illness and the ability to intervene with that. So what's exciting too is not only is that addressing the people we have working for us, but also a real commitment to developing a workforce. I think a lot of my colleagues that are here today, we've benefited from a friend or a family member who's worked in the industry and helped guide us into that. And we want to continue to bring new people into our group. And so this has been fun. We just announced this, but training our own EMTs, it's been out for maybe a little less than 2 weeks. Getting a number of people to sign up for that. I think we have 6 so far. But you can see what we're saying is we're trying to remove barriers to being an employee, to working in EMS. And that means paying people to learn the trade and start their career, and then develop all the way up through critical care paramedicine, community paramedicine, flight medicine, or for those of us like myself, able to move into other roles within the industry. So this is super exciting, this career development piece. And then that brings us, I mentioned, and we've talked a little bit about community paramedics. We have our community paramedic team here. Claire is one of our supervisors, and a couple others in the room. This is super exciting because this is the evolution of EMS for us. And it's how do we do what we've done well, so someone who calls for help, traditionally, call 911, the paramedics show up. If you have an emergency, we do a great job with that. What we've seen though is, a lot of people don't know where else to go, so they call for help. And we've evolved. I came to North to work with our community paramedic program about 6-7 years ago now. Our program's been in existence for, this is our 10th year. We're one of the pioneer community paramedic programs. And this slide I really like, it's super busy, so I apologize for that. There's a lot of stuff on there, but it's because we're doing a lot of stuff with our community paramedics. And what I would call your attention to is at the center of that is the patient or the customer, depending on if you're a North person, those are our customers. Traditionally, they're patients. And what that means is we really come and try to understand what the person needs, the person who's asked for help, and really try to support them with achieving what they're needing for their health, however they define that. So it might be risk reduction for some people, like we might not get them to be super healthy by an external definition, but at least healthier, using resources better, being able to participate in the community better. And this is super exciting to me, and it covers things like the technology that we talked about. It talked about medications, about getting to work with the other systems in the support systems, whether that's the county. I love down here where if one county's not answering the phone, you can cross the street and call another county, right? So all the fun parts about being down here. But what it's really, really about is that human connection. And so that's our medical direction approach, is that commitment to quality and continuous improvement and expectation for excellence, but really geared towards compassionate care that's individualized and accepting of the person who asks us for help. So I'm lucky because I get to live that ideal, but I wouldn't be able to do it without some of the other help. And I'm going to turn this over then to Rick to talk about some of that other support that we've had and the work we've done down here.
Thanks, Pete. Again, my name is Rick Wagner. I'm the Director of Outstate Operations, so I take care of everything that's not in the metro area, manage or direct the outstate areas from Aiken County down to Marshall, down to Lyon County. So, and we've been here in New Prague for over 10 years now. We started here in 2010 when the volunteer ambulance started having some issues with volunteerism and looking at different ways to manage the service, and we entered into the management contract with New Prague in 2010. We took over the day-to-day operations, and in 2011 we upgraded the license to advanced life support part-time license, and we've been operating an advanced life support service down here ever since then. So about 99% of the time we have an advanced life support unit on duty. The scheduler, the part-time ALS, just allows us that if we're overwhelmed, we can always drop down to BLS, but we rarely ever do that. So since we've got here, we've invested into the community and into the service, adding electronic charting, added Lucas devices to all of our ambulances. The Lucas devices are automatic CPR devices. At dinner we were talking, and Terry was relating that he was an orderly before he started as paramedic, and back then he was the Lucas device in the hospital that he worked in. And Dwayne, I'm sure you were the Lucas device many times.
Many times.
So we've upgraded all of our trucks to have power lift stretchers, and we're going a step farther by all of our new ambulances. We're adding power lift devices into the trucks so that we can continue to, avoid work comp injuries and injuries to our staff. Scott mentioned the second dispatch center. We just added that. We added 3 community paramedics down here this year, and as well as a community paramedic vehicle. In 2015, we renewed the contract, and we eliminated the subsidy from the contract at that time. When we first started in 2010, we had a subsidy that, and I don't remember all the details, but it was split between the city and the Queen of Peace Hospital at that time. And in 2015, we got rid of that language, and we took on full responsibility for that. So we've added resources. Back in 2017, we had some human resources and started staffing it up more because of the increased volume. So you'll see that a little bit more. 2 years ago, we upgraded all of our cardiac monitors, and last year we upgraded all of our IV pumps. And we continue to maintain our vehicles, as Scott mentioned, through our either locally or else through our maintenance garage in the Brooklyn Center area. And then we continue to meet on a regular basis with the mayor and the city administrator and police chief to do an annual update to update them on the volumes and everything. And I think our biggest advantage, and I think we talked about this a little bit in 2020 when we signed the contract, is, we really have an advantage geographically that no other service can provide that depth of resources, and it's based on geography. We have our New Prague service, which is in the gold area, or the pink area, and then our Faribault base in the blue area, and our Waseca base in the gold area. And we shift resources back and forth constantly with between those 3 areas, and we're able to, double or triple our coverage based on where the volumes are. So if we're getting overwhelmed in New Prague, we can bring resources up from Waseca or over from Faribault. And we also have Terry as our regional manager, along with our supervisors, one in New Prague and one in Waseca. We have a homegrown team. We still have a couple of people on our staff that were with the volunteer ambulance service back in 2010. So we have some good longevity there. And I think one of the things that we have to offer is that we're independent of any other healthcare service system in the state. So we take the customers wherever they want to go. And I think that's real important to some of the people, as we heard back in 2020. And I think one of our values that Scott talked about was relationships, and it really is all about the relationships. And we've been able to develop some very good working relationships with the New Prague Police Department, the Fire Department. Pete's been talking to the Fire Department and as well as Dr. Wilcox about helping out with medical direction for the New Prague Fire Department, and maybe developing a working relationship between Pete and Dr. Wilcox. The Le County Sheriff's Deputies, Lonsdale, Elko, Newmarket Fire First Responders, and Jordan Fire Department. And we've also developed a good working relationship with Montgomery Ambulance, where we help with some of their stuff as they're short-staffed once in a while. We've been able to help them quite a bit. So those relationships come in really important when you have, as pictured there, a multiple casualty incident like that. You got to have those relationships to be able to function on the scene of an acute situation like this to make it work well. So
That's on Highway 21, about County Road 64. two winters ago.
give or take, yeah. So this next slide, it just shows a little bit about our volumes on the right side, how we've, back in 2011, which was our first full year in service, we did a total of 740 transports out of our New Prague base, and in 2021, we did 1,461 transports. So it really does, and then on the left side, it just shows our response time, our median response times. We've been able to maintain good response times, a median response time of about 7.5 minutes. Very good for a somewhat rural area. In our metro operation, we shoot to be on scene at 11 minutes and 59 seconds, 90% of the time. So our response times here are about 12.7 minutes, 90% of the time. So we do a pretty good job of responding down here. And then the bottom one is more for the interfacility transfer times from the time we get the call till we get to the hospital to transfer the patient. So, and then I think we've become a big part of the community. I think we've done a great job being part of the Chamber of Commerce, doing trainings at local businesses, doing health fairs and career fairs at the schools, and demos for children at the different things throughout town, career days at the high schools, standbys at the sporting events, and of course the Zinke days were always part of that, and developed, it was a couple real challenging a few years ago with when you had the highway torn apart and everything. So we worked very closely with the city, and you just see on the left there is just the EMS Week proclamation from the mayor last year. So that was greatly appreciated to be recognized by the city for the services that we provide. So we've been fortunate for the last 10 plus years to be part of the community, and we thank you for that opportunity, and we really hope that you'll see it fit to have us here for the future. So just open it up for any questions that anyone might have.
Okay. Does any of the council have questions?
No, I didn't. I really appreciate the materials that you put together. This was a good read. It really gave me a good understanding of the different areas, and I love the idea of the response times. I was able to speak to a community member here just a few days ago, and he relayed to me just what a good organization he felt that you was impressed with the response times, which I think is extremely important, and the fact that you have 2 dispatch centers, which I love that redundancy just in the event. So I don't have any questions because you've put so much great material here. So thank you.
Anybody else? Go ahead.
You want me first?
Whatever.
I have a few comments and then just some clarifications on some of the material that you provide. Well, first of all, thanks for the service that your company and North Memorial has provided to New Prague, and also the transition from 2010 to evolve our service in New Prague and provide higher standards of care in EMS. So thank you guys for what you've done, and thank you for your staff, especially over the last couple of years when it had to be challenging during COVID to manage your staffing and provide the services on a consistent and reliable basis. So thanks for all the work that you've done. And also thank you for the community involvement. Zinke is a very important event for us, and the work that you've done there and other areas of supporting the community in other ways through the fire department and your relationship with the police and other services. In the material, it refers to recent discussions with the New Prague Fire Department on our willingness to assist as needed for New Prague Fire and Rescue. What types of things is that referring to?
That was what I mentioned about the medical direction. A couple of our people are on the fire department and doing just the training and stuff. And
Okay,
as the New Prague Fire Department, as first responders, they have a medical director, which is Mike Wilcox right now. And Mike, as you all well know, is a very busy guy. And I think the fire department is using our first responder protocols anyway. And
okay,
Pete and Mike have a good working relationship, so it's just enhancing that relationship. So give Mike a little bit of time, and then with Pete, if Pete's involved, it gives our people the ability to do some of the training and some of the hands-on skills and things with the first responders out of the fire department. So
okay, thank you.
just looking to improve that relationship a little bit or enhance it.
In the material, or under the narrative about community paramedicine, it talks about a total of 20 community paramedics, 3 in New Prague, and we anticipate hiring 9 more at the end of 2022. Are you contemplating possibly hiring more for the New Prague and Faribault area? Or?
If we get busy enough, I mean, and Scott, maybe you can talk about the vision about that, but our vision is to try to build it up wherever we can. We've had different pockets of success, and I'm not real involved with it, but we're real proud of our Alexandria region, which is where I'm from, but we just signed a contract with the police department to have the community paramedics work with the police department on some of the mental health issues and stuff, and some of the repeat customers that the police department handles. And we've done a little pilot project with them in conjunction with the community paramedics, and they've found it very helpful and found ways that they're going to use us over the next year to try to spell off some of the work of the repeat calls that take up the police officer's time, and we'll send a community paramedic out to see those patients and get them the social services that they need and coordinate their care a little bit better. And so it keeps the police on the street and gets the people the appropriate resources that they need so that they don't have those repetitive calls. So Pete could go on for hours on success stories that he's had with that system in Clara. So.
Yeah, that's kind of an area I didn't really think too much about, but the paramedics dealing with mental health issues.
Yep.
That focus, so that's interesting. So the 9 more anticipated, and that's not necessarily, that wouldn't necessarily affect New Prague.
Well, it could if the volumes pick up, if our utilization of the, when it starts building up and we get busier, we're willing to build up wherever we're needed. If we can get contracts with different agencies, we're doing one up also in Douglas County with one of the insurance companies, Prime West, which is a medical assistance carrier. We're doing a program with them where we're signing a contract with them to help take care of some medical assistance patients for them. So it's kind of about finding the patients and finding the niche for the community paramedics and then going where we're needed and build on it. But we initiated the expansion back in 2020 and we've got a community paramedic manager now, and so our goal is to expand in the outstate
Does that have to stay in the licensing area?
No.
Okay.
Nope, it's not tied to the ambulance license at all, so
Okay.
it's separate.
Okay,
So,
thanks.
yep.
Hiring and retention, you refer to the benefit of being part of the Faribault region. That seems to make a lot of sense, and the ability to backfill seems to be very important advantage. And I'm assuming you've used that quite a lot over the last couple of years with COVID and dealing with issues and things like that. Under the history of success and proposed operation plan, I just was wanting a little clarification or better understanding of and maybe that's what you just mentioned a little while ago, where you shoot to have advanced life support 90% of the time.
And I think, I think the thing about that we've done is we've proven that we're successful, and we're proven that we've added staff when we needed to add staff, and not just promise to do what we need to do in the future, but we watch the statistics, and like I said, in 2017, we were starting to get a little tight on staff, and that was when we had only 1.5 trucks, and that's when we expanded to have 2 trucks on 24/7. So we monitor the volumes and the activity level and how much time we're out of town on transfers and things, and we'll adjust our staffing as needed on an ongoing basis. So
So could you just clarify then, what are the standard schedule that you staff here then for?
We have 2 trucks on, one of the crews is on premise all the time at the station, and the other crew is off premise right now at home or within 8 minutes of the station. So we have 2 crews on 24/7.
And they're both ALS then?
Yes.
Okay. So that's just 2 daytime or 2
Around the clock.
24?
Yep,
Okay.
24/7.
A primary and a backup 24 hours a day ALS?
Yep,
Okay.
yep. And then if,
It's probably obvious as you read that, but to me, I just.
yep, no, when you're not doing it, when you're not in it, I get it. And then like, you know, if we start getting short, we can move people up from Waseca or over from Faribault, or we'll, you know, if it's been a busy day over here with transfers, we'll send, and there's another transfer, we'll send the Waseca crew over, the Faribault crew to take another transfer just to keep that crew fresh. Or if we need to, we can call the Metro resources down too, because all those transfers they don't have to go right away. So we have the ability to shift our resources around geographically, just because, you know, we have the geography in our favor.
The last page, where you talk about response times, to me, I'm not sure what to compare it with, but looking at it, seems like they're very good response times. They seem very acceptable and very good. I'm not sure how you grade that, because unless you have somebody doing it with you in the same geography,
Yeah,
how do you?
I think my opinion is if it's, Hennepin County has an ordinance that mandates their response times of 11 minutes and 59 seconds 90% of the time. That's the strictest response time guideline in the state. So if we're better than that and are consistently better than that, I view that as pretty good. And why in 2019 it was that much, was lower, that's a good question. I thought that was a question you're gonna ask, because it was a little lower in 2019 and we've gone over those numbers, and it was just, that's the median, that's not saying that there's not longer response times, it was just, there was probably less calls out in the county that we responded to than in that year, but.
I appreciate your comments, whoever prepared this, on the last page, and it talks about the differences and why support the renewal. So I think those are good comments. The other questions I had really dealt with the cover page. You make reference to 98% of our customers' families rate interaction with us either good or very good. I think that's great. Do you have specific information for the new Prague PSA?
Yep, that is from the.
That is the new Prague
Yep,
PSA?
yep.
I didn't know if that was.
And we've gone through a couple of different companies, and we're on a newer company now that we send a text message out to them, and we keep track of those by region and.
You do
and
that
by the
annually?
outset.
Or?
We do it we have a set criteria. We don't send it out to the people in crisis or the people that were unconscious, obviously, but we send it out on a regular basis to almost all the patients.
Is that something you've been providing to the city in the past?
Yep, I think I think we've given the scores a rough, you know, similar to that, what the good to excellent care, I think we give that rating of care to the city.
Okay, I'm not sure that we've seen it.
No, I don't think so. And
Okay.
actually, we met with Josh a couple of weeks ago, as the new guy in the block, and talked to him about, you know, historically, we met with the mayor and the city administrator and police chief, and used to be the hospital, and I said, you know, if that's what you want to continue to do, or else we could certainly come to the city council and do the annual report. It doesn't,
Well, and
wherever, I mean,
and and that was one of my comments. I guess I would like it more than annual.
yep, and we
Maybe.
can do that. I mean, in some of the areas we do it.
You know,
where-
because I think it's important. And
Yeah, it's about the relationships, and
Yep.
you know, we do it in Wisconsin, a little bit different operation over there, but we meet with them on a quarterly basis and actually developed a subcommittee, and it helps when you can explain this and ask questions, because
it's still fresh.
it's still fresh, or you hear, oh geez, somebody waited 45 minutes for an ambulance, and you
Yep.
stew on that for a
a
year.
year.
And then you, of course, you don't tell anybody that, right?
Mhm.
So, you know, but if you can meet on a regular basis and have conversation about it, then you can dispel all of those myths and find out what actually happened. And usually there's a reason for those longer response times, if they were. Sometimes, you know, when you're waiting for an ambulance or a police officer to get there, it takes forever, right?
Mhm.
When it's actually a couple of minutes.
On the bottom of the cover page, it refers exciting new healthcare options will be introduced into your community over the next couple of years. Is that making reference to community paramedicine?
I think that's part of it. I think that, there's, and Pete, maybe you want to talk about the evolution in EMS, what that means.
Community paramedicine is definitely a core to that, but it also talks about, or we're also referencing the advancing of telemedicine. Again, trying to bring the right resource to people at the right time. I think some of the training that we've just briefly touched on, but we just purchased a couple of a really fancy simulator that allows us to do training and helps bring, as we're advancing with our different pieces of equipment, different ways to problem solve, the ability to train real time and practice before we're dealing with real people. And then also a commitment on the first responder side to some advancing best practice for mental health and well-being for our responding team members. And some, one other thing that I'm forgetting, but those are kind of the broad categories that we're looking at.
Okay, thank you. My last question, I guess, or comment is really regarding the comments then on that same paragraph, and maybe I'll address this to you, Mr. Sampe, which is kind of related to the choice issue, but absent of other business interests in your community allows us the latitude to always do the right thing. Maybe I could get some more clarification with that, because I'm not sure what you're trying to say there. And I realize North Memorial has PSAs in most of northern Hennepin County, and you obviously have North Memorial Hospital in there, and Alina has ambulance in northern Scott County, and they have St. Francis, and so I'm a little puzzled as to what you're trying to say, that if it's just a
little different in this state, but you'll see more of what we do. But for instance, most hospitals across the country will have an ambulance service to bring patients to that health system for the downstream revenue. We bring very few patients to our hospital because we don't really serve that area super densely. We have some ambulances in that area, Robbinsdale and around the cities, but when you look at this map, we're not bringing these patients back to our health system. We're bringing them back to the local resources that's most appropriate to that area, where the patients want to go. And so that's where, when I heard Rick mention, we actually function more independently in that respect. It's more about, we try to work with the communities and the customers in those areas. Our goal is not to get them in the north system.
Yeah, it's puzzling to me because you obviously have a lot of business interests in northern Hennepin County and Maple Grove now, and in other areas. And it kind of puzzles me in a little bit, because then you're saying Alina ambulance don't have the discretion to make the right decision if
I'm sure
in
they
different
do.
markets or things like that, or
some of those health systems have hospitals more across the whole state, and they may have an emphasis on getting those patients to there. I can't say that, but I can say we certainly don't, because we're not in that position.
Okay, I'll take it for what you say. I'm not sure it makes sense to me, but I understand what you're saying anyway. But because isn't it common that a lot of health systems have their own ambulance?
Common.
A lot of the PSAs, rather.
In this state, it is. In fact, forget what the study that came out. Did it said health center owned ambulances? I believe health center owned ambulances transport 77% of the patients in this state, even though they only represent about less than 25% of the actual ambulances. So just kind of interesting. They're the ones transporting the most, just like us, the most patients. Okay. Now, some of that's because of the dense populations. Maybe they're stationed, and that's going to have a big factor of part of that stat too. But in other states, not so much. When you get in other states, you rarely find, not rarely, but it's not common to find a healthcare system that owns an ambulance service. It's going to be more municipal owned, those kind of things, or private.
Okay.
Or corporate. Or like an AMR or
exactly
something like that.
Yeah, and then you get into higher price structures and all those kind of things. Exactly.
Well, when I look at the PSAs and try to understand this whole thing, it's really kind of confusing to me. It's like that cliche, which I'm trying to remember, it's like a how does that go? The committee is trying to design a horse and it turns out to be a camel.
Right.
And
Right.
and that's kind of what
Yeah.
what these PSAs kind of,
There's a
kind of
lot.
were locked in 20
Exactly.
years ago and they don't.
And some of them
seem to-
change once in a while, and, you know, exactly, there's different ways of looking at it. One way of looking at it, you know, especially in your positions, is that you know exactly who's gonna cover your territory. In some parts of the country, you know, somebody can come and go. You know, if you have a private service like you mentioned, they can just shut down business. And, you know, most of those states don't have laws. They can literally leave within weeks. Or you can have the opposite situation. Maybe you have a lot of people with a good insurance in a particular area, and you might have a lot of ambulances. When you have a car accident or something, you're gonna see 3 or 4 ambulances showing up fighting for the patient, whoever gets there first. And that's just as dangerous. And that's where the PSA stops those two situations, more or less.
Thank you.
Yeah.
Thanks.
I want to thank all you guys for your service. I get to meet these guys on a weekly, daily basis type, and so I thank you guys. You work great, and I would like to actually get some frequent flyer miles.
My comments were answered with Councilmember Wolf's questions, so, except one. The paramedicine, how do we get the hospital to work with you? Or the clinics to work with you?
Go ahead.
I think part of it is, as we continue to do our good work, people come and ask for assistance. And because, you know, at the core of our work is the person that we're caring for. As we come to understand their needs better, or their needs become clearer, the hospitals and the clinics will start to follow, they start to recognize. The story I can tell you is more, not to a county or hospital, or not to a clinic or hospital at this point, but it's just a county service. And what's always reassuring is how good everyone's intentions ultimately are. But it's figuring out that the person who was at this county service that we were trying to collaborate with, it turns out that person had left. They were no longer there. But that hadn't been communicated to the individual. So as one of our community paramedics going to the county and saying, hey, no one's answering my call. I'm sure it's not intentional. What's going on? And just figuring out that, oh, it's a new person there. And then what turns out is that person is like, I've been trying to solve this problem too. So it's by having, I believe in our spirit of collaboration and willingness to interact, and that with time then more will come in. That collaboration just builds and builds. That's been our experience everywhere else that we've worked over the last 10 years. And it's also then through building those relationships. So for like our hospital partners, it's connecting with them. Oftentimes it does come because of a crisis or a problem that we're trying to solve together. But then once we start that problem solving, it builds on that. So
Okay. I want to respect everybody's time, and I know we're getting to the end, so. Does anybody else have any questions for North Memorial? Otherwise, I want to thank you on behalf of the city also for providing good service since 2010. And, you know, it's been a good partnership so far, so.
Thank you.
Okay, thanks, folks. Thank you.
So I guess I would say, being that this is an open meeting, you are allowed to stay.
Okay.
But we would ask that you step out. We did ask the same of Mayo so that you guys wouldn't feel like they're collecting answers from you guys or something like that. So,
Understand.
thank you.
Thanks, we'll see you guys. Nice meeting you. What's new, Ron? Yeah, I said, what's new?
The weather's warming up.
You need a haircut.
You're very good on paycheck today.
Thanks.
Take donuts?
Yes, I did. I took scones from Patty's place this week, this month.
You'll never try to trick me into taking
No, I won't, cause it's been costing me.
I'm guessing you said they were 3 days old.
No, I haven't gone to the dollar shelf at the bakery yet. I just-
You dropped your mask there, Rick.
How's it going, Ron?
Well, he's good. Wife Kathy wanted to go out to eat last night. It's Lent. I said, we shouldn't do that. She said, well, we haven't been any place. I want to go someplace expensive. So I took her to a gas station.
That right.
It wasn't that bad. I just let her use the restroom.
Mayor, I talked to my buddy Gene Smith this morning.
Did you?
He had some greetings for you, but I probably shouldn't say them.
No, but he's a good guy.
He is a good guy. Don't tell him I said that.
Okay.
I'm not sure if I still, so it's fully staffed with ALS 24 hours a day, just the 24-hour cycle.
Yeah,
And then
so
the backup crew is not necessarily ALS.
oh no, the backup crew is ALS too, they said.
And that's 12 hours?
Well, they said that they have somebody 24 also. Backup crew.
Okay.
Now,
Bruce, Mayor, just so you know, we are live,
thanks.
if you're gonna chat.
Mm-hmm. Appreciate that.
Basketball game started yet?
That Crawford Standard, that's all
They were
open
just chatting
space.
up
People
there.
can park there now to go to the post office, right?
That's, well, I can't give that permission, but,
Oh, I know you can't. Just
hello.
That's building up more and more all the time.
Good evening.
Good evening. I'm just gonna
Yep.
be your AV guy, and then I'm gonna turn it over to somebody else here. So.
Sounds good. This is scrolling up, down. Yeah. Cool.
Okay, ready to go?
Yes, go ahead, Dr. Herman.
All right, well, thanks. First, we want to thank you for allowing us the chance to present an RFP, and we're really excited to be here again. And we're going to talk primarily about our plan for Mayo EMS in New Prague. First thing I thought we would do is just introduce ourselves, and some of us will be talking to the group. And so my name is Marty Herman. I'm a family physician. I've been working here in New Prague since 1993, and I've been the medical director for Mayo Clinic in New Prague and Wasika since 2011, and in New Prague, and then a little bit shorter than that for Wasika. I partner with Mackenzie Miller, who is my administrative partner, and the two of us both oversee both New Prague and Wasika for the Mayo Clinic Health System. So let's go ahead and just introduce ourselves. I've introduced Mackenzie.
Absolutely. So Mackenzie Miller, I'm the site administrator for the New Prague and Wasika hospital campuses. Been with Mayo Clinic for 9 years now. I've been with New Prague for the last 5, and in my current role, just coming up on 2 years here in June. So excited to have the opportunity to chat with you today.
Dr. Luke?
Yeah. My name's Anu Luke, and I have been at Mayo for 20 years. I have been the medical director for Mayo Clinic Ambulance for the last 6 years, and currently in an associate medical director position.
Good to see you all again. Paul
Yes.
Drucker, Senior Director of the Ambulance Service for about 6.5 years now. I've been at Mayo Clinic for almost 25 years. And again, appreciate that opportunity to take the time.
Good evening. Thank you for allowing us the time here. My name is Tom Fennell. I'm the Regulatory Officer for Mayo Clinic Ambulance. I've been with Mayo for just about 29 years now. It'll be at 29 in just a couple of months. And I oversee service level licensing, and I interact with communities like yourselves and councils and boards and those types of things as well.
Dr. Williams?
Hi, my name is Paul Williams, one of the ER physicians in Mankato. I've been with Mayo for 5 years. This area and southwest Minnesota and south central.
Okay. Thank you.
So several of us will be talking, during the course of our presentation here, but first, you just want to talk about some overview plans for New Prague. New Prague is part of Mayo Clinic's Bold Forward strategy, and it's basically a 10-year plan strategy to bring service excellence and knowledge and technology and talent to communities throughout the Midwest, including New Prague. Dr. Ferrugia, who's our CEO and president, has his basically our Bold Forward statement, and it's summarized in a couple of simple slogans. One is to cure, connect, and transform, and another is when we talk about how we treat patients. We want to provide the right care at the right time and in the right place. This is how we'll present today. I'll provide a brief introduction, and then we'll turn you over to Dr. Luke, who will flesh out our EMS proposal. And then she'll be assisted by Paul Drucker. And then finally, Mackenzie and I will wrap up with a couple of closing comments, and we'll open up for some questions. So first is, who is Mayo Clinic Ambulance? And basically, the providing medical care in people's homes is nothing new for Mayo. They obviously did this before the automobile. We have greater than 100-year history of providing service in homes and into communities. Mayo Clinic purchased the Gold Cross ambulance in 1994, which was rebranded as Mayo Clinic Ambulance in 2019. Mayo Clinic now services 14 PSAs in Minnesota and Wisconsin, and we have a map of that to show you here in a little bit. Also, it involves air ambulance systems. We have helicopters in both Minnesota and Wisconsin, and airplane travel as well. I skipped into a blank. So this is the Mayo Clinic ambulance service area, and Mackenzie, do you want to speak to that?
Absolutely, thank you. So this slide shows our primary service area for the Mayo Clinic ambulance as it stands today. Mayo Clinic's ambulance goals is to provide Mayo Clinic care closer to home. The goal is never to redirect or disrupt where a patient receives their care, but rather to implement technology and deliver models to allow more of their care to happen closer to home. So these are the areas that we have. They do align very closely to where Mayo Clinic Health System communities exist within the state of Minnesota. Oops. That particular one. There we go. Dr. Herman, I believe that this is.
Mm-hmm.
Yep.
So as Mackenzie said, integrating with the community is a primary tactic of how Mayo wants to approach the future. And New Prague is really poised to benefit from not only the talent, but also the technology that Mayo Clinic is ready to install into New Prague. And we'll give you some examples as we get down to the end of the presentation. But primarily, we would like to integrate, from home to hospital and back to home again. And this requires a collaborative care model, really from the start of the patient encounter all the way, into the hospital, and then possibly providing services into the community, trying to prevent hospitalizations is a major tactic. But we'll have a little bit better understanding of the model after you hear Dr. Luke speak in more specific terms. But I think I'll take this moment to welcome Dr. Luke to provide the rest of the model here.
Thank you, Dr. Herman.
I've just been moving that one way or the other.
All right. There we go.
There, it's very sensitive.
Perfect. Well, thank you, Dr. Herman, and thank you to all of you for inviting us and letting us speak today. So I want to talk a little bit about Mayo Clinic Ambulance in the first place and what we are made of, and then we'll kind of go into the proposal a little bit. So we have 650 team members, and they provide multiple different job purposes, such as dispatchers, EMTs, paramedics. We have community paramedics in our service. We have critical care paramedics as well as critical care nurses. We have respiratory therapists and perfusionists that work with us. We have specialty care teams, billings and claims specialists, administrators, and pharmacists. And we also have a cadre of physicians that I'll show you who help provide medical direction. So it's a large team. We all operate under Mayo Clinic values. And Mayo Clinic values are really about care to the patient, the best care for the patient delivered at the most appropriate time, at the most appropriate place. And our values are rich ties, which are the respect, integrity, compassion, healing, teamwork, innovation, excellence, and stewardship. And just as an example of how we do, in our last survey, where we actually sent out surveys about our care, Mayo Clinic ambulance care, and the categories for staff knowledge, for courtesy and care, pain reduction and control, respect for race and culture, concern for privacy, concern for safety and overall quality of care, we actually scored 96% of the time in the excellent or very good and good categories. A little bit about our accreditation. So accreditations, we go to outside agencies to validate the care and the service that we provide. Many of these are voluntary. The last one, which is the training for EMS professionals, is partnered with our paramedic school, and that's something that we do get as a requirement, but all of the other accreditations are voluntary. So we have CAMPS and CAS, which are for our entire service, and then ACE, which is for our dispatch, and then the business aircraft operation accreditation is for our aircraft. So we are one of the only agencies that we know of within Minnesota, Wisconsin that carry all of these accreditations. Oops, it wants to skip over the physicians. So we have a large team of physicians that work, and this is a representation of the physicians. It's not everybody. So Dr. Zietlow serves as our medical ambulance board chair, and he's the overall medical director. I'm his associate medical director, and I'm also the chair of our pre-hospital division. So I work with a lot of physicians that work with EMS. We have a practice and an education chair in Dr. Clausen and Dr. Maimur. You've met Dr. Williams, who is our medical director here in Southwest Minnesota and works with a lot of other agencies. We have specialty care medical directors. So Dr. Gleich serves as a pediatric specialty team, and Dr. McCoy works with our community paramedics. And so this has all been in the last few years that we've really built this team with a goal towards moving towards where we can provide care throughout our system with solid medical direction. So what's new and exciting? We're doing a lot of new things. Our evidence-based patient care guidelines have always been evidence-based. They continue to be, and we're also looking at creating a continuity or an integration with what we do in the hospital, so that the care that's provided right from the first encounter with our patient is consistent all the way through. And potentially even back to the home. As Dr. Herman said, patients home to the hospital, the care in the hospital, potentially perhaps preventing hospitalization, but also care after hospitalization. We have a couple of new programs. One is the Et3 program, which is a CMS-directed program where we are one of less than 200 programs in the country and the only one in Minnesota that got this award. And it is looking at how we can provide care using telemedicine in a patient's home to perhaps treat them right at home, potentially take them into a clinic, an alternate destination, rather than always to the emergency department, because that matches what the patient needs with what care we provide. Community paramedicine is another way to care for patients, is a community paramedic visits a patient's home, potentially can draw labs, can potentially do tests, can potentially deliver medications so that they don't necessarily always have to come into the clinic. We have recently redesigned ambulances to promote safety and efficiency, and that was all provided by our team members. They had input into all of that. So that's a little bit, there's one more, I think. There was one on dispatch. Okay. Okay, so let me talk a little bit about a proposal, and I think you all have received written documentation of that, but just to summarize a little bit, our proposal is to provide a on-site crew starting at 7 a.m. to 7 p.m. and then another crew that does 7 p.m. to 7 a.m. We would then provide an additional crew that starts at 10 to 10, and then overnight 10 p.m. to 10 a.m. would be on call. And this matches, and this is based upon the projected needs in the community based on the projected number of calls. And so we see the number of team members probably being around between 16 and 18. There probably will be a little bit of give in terms of the timings, but again, it is planned based on the projected volume, what we have seen, and what we project with growth. Our crews are given an excellent employee compensation and benefits, and it's something that's revisited and shared or reviewed with the market to see that we're actually doing the right thing and giving them the appropriate amount of money. There's a lot of components of this in addition to the pay. There's several benefits such as health insurance, disability insurance, pension plan, a retirement plan, and career investment program and PTO. So we have quite a few benefits for our employees. And then our employees are actually very engaged in our frontline management. They get the opportunity to participate and contribute to a number of components, including operations, our patient care, and speak to our best practices to make sure we're doing the right thing for the patient. So they've been involved in things such as fleet management, materials management, what materials we need. Reportable event review, or if there are cases that we're concerned about, they participate. We look to see how we can improve care. Medical direction, writing our guidelines, helping us with that, with our medical direction team and our physicians. It's a team principle, and then they can be involved in ad hoc work groups as well to try to improve those. We take safety very seriously. We have screening for drug and alcohol both initially and then again during the random times during their employment. And then there's a vehicle management program which has to do with safety, how well you drive, and you do get evaluated on that, and our team members are graded. And that includes our physicians who drive our response vehicle as well. So our proposal is to have 3 fully equipped advanced life support ambulances to be kept here in New Prague. We have a very proactive fleet management system. We get about 8 to 10 new ambulances circulating, across our fleet that are updated annually. We'll provide all the necessary equipment, medications, and supplies. Our team members are empowered through our guidelines, which are written, evidence-based, and directed by our physicians. And they can to make those critical decisions at the bedside. And then we have our emergency communication center, which actually already does a great deal And they dispatch, they provide pre-arrival instructions. We would be a secondary answering point with we would coordinate with public service access points in Scott, Rice, and LaSure counties. Currently, we do medical instructions for 911 counties, for 911 calls for 15 counties. We handle about 20,000 a year. So I'm going to turn over the next slide to Paul because there's some additional considerations that he'll go through, and then we'll come back whenever you have any questions. Thank you.
Thanks, Dr. Luke. And I think these topics are all illustrated in your packet as well, but these are questions that came up 2 years ago when we had the good fortune to present, and just wanted to come back to these. Facilities, certainly you have a great facility here in town. We'd be interested in working with you to lease that space if we're selected to operate the ambulance service, and follow best practice and fair market value in determining relationship in that respect. A question about patient choice, and will we as an ambulance service impact patient choice? And I think there's two perspectives on that. The first is just 911 calls. If we're called to a 911, when we respond to a patient's home, we follow the EMS statutes that we're transporting the patient to the nearest appropriate facility. The question may come up, well, what if I want to go to this hospital that's outside the primary service area? And I think that becomes somewhat of a medical decision about whether the patient's stable and or is it reasonable to transport a patient outside the primary service area when there's a hospital in the community that can provide all the necessary services. But the bottom line is it will follow the statutes and follow reason in decision-making that in collaboration with the patient. In respect to interfacility transfers of patients, an ambulance service shouldn't have any bearing on the destination of a patient on an interfacility transfer. Patients at the hospital in New Prague, they want to go to a hospital. That's a determination by the patient and their provider on where that destination is. We provide the services to get them there safely and provide good care, but that's not within our purview on decision-making. Time needed to stand up operations, that was a question that came up 2 years ago, and I think assuming a May 1 of 2023 start time if we're selected, that's more than adequate time for us to prepare a transition of operations in all respects. Reporting and accountability with the City of New Prague, I think it's illustrated in the RFP that there's currently annual meetings. We'd like to suggest, at least if we're selected, that there be more frequent intervals as we get to know each other, and that we'd work together to establish performance standards so that you can measure us on how we're delivering services to the community, both in 911 response and interfacility transfers and responsiveness to the hospital to move those patients where they need to go. And certainly, as the city holds the license for the primary service area, any issues with that primary service area accountability back to the city so that you're aware of any issues in respect to EMS regulations that may have a bearing on the city, that we would be transparent in those respects with you so that we're all working together. Coverage of the primary service area, operationally now, trying to balance 911 calls and interfacility transfers. It looks like the volume in New Prague and the primary service area now is somewhat split between 911 calls and interfacility transfers. If we're transferring a patient out, that patient, then the primary service area coverage could be threatened. Our standard operating procedure now is that we would not leave the primary service area unless there was another ambulance to cover the primary service area within the confines, unless the patient had a life or limb threatening issue that required emergent transfer. That's the only time that we vacate the primary service area, but we would ensure that we had another ambulance coming from one of our other service areas or partner with mutual aid with surrounding communities to make sure that the primary service area is covered. Again, that's standard practice now, and we would continue that as well in New Prague. License of business risk. We respect the fact that the license is owned by the city, and we will honor that on your behalf in every way that we can. Business risk, we assume no expectation of subsidy. The business risk is on us to operate it in a financially prudent way. And then as well on the billing and claims process, we have a 20-plus team member billing and claim service within Mayo Clinic, all Mayo Clinic employees that already do all this work now for 75,000 plus claims every year. So we would assume as well all that work with patients and their insurers. And then recruitment of team members in today's employment market, just wanted to acknowledge that's a tough issue with a lot of sectors right now, and it's an issue in EMS as well, here and nationally. We enjoy great support from our human resources recruitment partners and have access to a number of recruitment strategies that will help us in recruitment of team members to make sure that we had appropriate staffing to meet the needs of the community. And as well, certainly if we're selected, we respect the sensitivities of any current North Memorial team members. If they were interested in employment with Mayo Clinic, we would be happy to work with them. I think the question last time was, would we just assume them into Mayo Clinic? And certainly I hopefully understand that we would need to do all the necessary scrutinies of any new employee, but we would work with anyone that was interested in employment with us if we're selected. So I think I'll turn it back over to Dr. Herman, talk a little bit more about the health system and us.
So we just have a few comments Mackenzie and I would like to make just in regards to the implication of the hospital as a whole and the medical delivery that we're providing here in New Prague. I've never been more excited to be a physician in New Prague, and my physician teammates that work here every day, there's in the neighborhood of 25 of us that see patients in various specialties in New Prague, and we're about to get bigger. We feel that integration really from the get-go is so critical now with technologies that are coming forward and being able to look into the medical record, being able to have the same vetted treatment plans, between EMS and the emergency department and then in hospital and back. There's never been a greater need to have that level of integration, and that's probably one of the biggest things that's added by this opportunity, in my opinion, for the city of New Prague and its future of healthcare. And when I think of this proposal, I'm not thinking of the next 3 to 5 years. I'm literally thinking of the healthcare that's provided in New Prague for the next 100 years. And we've been working in a system for the last 70 years that's been variable with a lack of integration, and this is the first time we've really had a chance to get some traction in that regard. So we have a great opportunity in front of us, and I think it's really exciting. I got to train myself to look at this, so I just don't want to have to put my glasses on. So if I stand back a little way, I'm okay. But one of the premises of that statement is that there's a serious commitment in Mayo Clinic to reinvest money back into the communities. And New Prague is a prime example. We've had several major capital investments in the last 5 years, and we're about to entertain some more. This is one that we just finished just a couple of weeks ago. So this is a $4.5 million surgical expansion into our current setting in the hospital in New Prague. It basically brought 3 ORs up to state-of-the-art Mayo Clinic expertise in terms of technology in the OR. This includes a surgical robot, which very few community hospitals would possess. We've been performing robotic surgery now in New Prague since November, and we've had great success getting people back to home and reducing hospital days for them quickly with that procedure. We had an opportunity to have some of our city partners take a look at that, put the bunny boots on, and this is just one example of how Mayo Clinic will reinvest technology and talent back into our community. Another, in regards to talking more about talent, if you look at this slide in 2018 is the list of our existing practices. And again, these are our Mayo Clinic primary care practices and specialty practices that existed and worked in our community in 2018. If you look to the right and you see what we've added by the end of 2022, another list of specialties that are on top of what we had in 2018. And this was remarkable. This is a tremendous amount of recruitment, a tremendous amount of commitment by Mayo Clinic to make this happen. And throw a pandemic in the middle of that, and you can see the intensity of what Mayo Clinic desires for New Prague. And bringing this level of expertise doesn't just make us kind of your typical community hospital. It's going to actually allow patients to stay closer to home for various conditions. We're never going to have a cardiac catheter lab. We're probably never going to do organ transplants in New Prague, but we can provide much more care than we currently do. But we're going to need to be fully integrated, and we're also going to need top talent, recruiting power, and then the technology that these surgical specialties in particular are going to ask for, not to mention our medical specialties. But when I look at this list every time, my heart just kind of beats fast, because I've been a doctor here for a long time, and I've never seen this kind of progress. And again, I'm using the pandemic to just exemplify that, how challenging that is, at this time. So New Prague is really positioned to benefit from all of these interventions, and I certainly hope that we strongly consider the EMS venture as well, because it's just one more piece of our puzzle. Mackenzie's going to talk next about what comes when we expand our practice in New Prague, and in a nutshell, it's a tremendous amount of employment opportunities. And so, Mackenzie, do you want to talk about that?
Absolutely. Thank you, Dr. Herman. I'm really excited to talk about the additional employment opportunities that we've been able to add. Over the last 12 months, we've added over a dozen career opportunities here in New Prague. Current state, we're in recruitment of over 30 positions. Those range from new physician specialists that'll be New Prague-based, advanced practice providers, again, that'll be New Prague-based, additional RN positions, surgical technologists, lab, radiology, as well as our EVS teams expanding to meet the greater needs of our increased census and the more patients that we're seeing every single day. Currently working through all of those, but continuing to add that to that group and to the opportunities that we have here in New Prague to support our community. Additional community, just like to highlight, we had the great opportunity to help with community grants in 2021. We were able to donate over $22,000 in community grants, as well as 850 volunteer opportunities and volunteer hours, with different community organizations. And we were able to partner for the career exploration programs to allow high school students and college students to come through and visit the hospital and see what it's like to work in those healthcare environments. Additionally, we offer childbirth and breastfeeding classes to the communities, and we're able to partner. These are some of our photos of our staff from the Checkout New Prague, where we could partner with the New Prague Chamber. We brought in the big inflatable lung, along with some expertise in smoking cessation and the risks of vaping, to try and help impact the youth of our communities. And with that, I think that was our last formal slide. Opening to the group, though, for questions and how we can answer anything that we may have not addressed clearly in the presentation. Yes.
Any questions from the council?
I do have one. I didn't see in your materials, given a community of our size and also kind of the rural area around it, what would be your average response times?
Sorry, I'm here taking down the computer. I might as well answer that. For an emergency call?
Yes.
Yeah, we track this on a daily basis. And our emergency calls are, we call them priority ones and priority twos, which are an immediate response that's required. From the time our crew is notified until the time the wheels are rolling, our average is 36 seconds. It was today. That it ranges from anywhere in the mid 30s to the low 40 seconds is what that's 24 hours a day.
And then your response time to actually get to where the patient is?
That's going to vary on the mileage that we're going to have
You know, this primary service area is about 150 square miles. And so our travel distances are not going to be that great. But we still have a lot of factors to go into that. You know, what's the weather, what's the, you know, the other conditions that we have. And so for us to put that time limit or the time cap or estimation on how long it's going to take us once we start to roll, that's going to be real difficult once we, with all those factors, you know, so.
So, and that's why I premised my question with, given the community of our size and our makeup, do you have another community of similarity that you could say, okay, our response time in something that looks similar to New Prague is fill in the blank?
Yeah, I think we can, happy to follow up with data from Fairmont, Minnesota. Population is very similar, call volume likely would be similar, our staffing model is very similar. Primary service area is actually a little bit bigger, but we'd be happy to follow up with data. Exactly what
I'd appreciate that.
Yep.
Thank
So,
you.
And just to be clear too, you're looking for from the time we are moving until we arrive on scene. What's that average?
Yes,
Okay.
yes.
Yeah.
Because of course, a concern is that, you know, you've got someone that's in a stressful situation and, you know, how long, you know, for me, if I were in a stressful situation like that, 1 minute would seem like 10, right? So I just wanted to kind of get a feel for our constituents of.
If I could add, we'll get that data and bring that back to Josh and Paul, so you have that. One additional piece to that is what Dr. Luke spoke about, the medical priorities and the dispatching process as a secondary, primary answering point, public safety answering point. We're doing 20,000 pre-arrival calls, meaning the primary PSAP, Homestead County, for instance, Blue Earth County, they hand a 911 caller over to one of our dispatchers who is going through a scripted process to identify the acuity of that call and the issue with the patient. So they're directly talking to the 911 caller. That gives us confidence then as well, based off the results of those questions, what the acuity is and how we respond. And I would say about half the time we actually reduce and don't go lights and sirens because the information provided and the confidence and I think the comfort that the dispatcher can provide to the caller about what's happening helps to kind of assuage that when the situation isn't quite as stressful. So to distinguish that too on the data, we can provide priority 1 and priority 2 response. Likely there's not much difference, but we'll provide both those for you.
I do think it depends, like Tom said, it does depend upon the distance from the station to get
Of
here.
course, yeah.
And so we may be able to divide that up in terms of shortest distance to longest as well, so that might give us a little bit of range.
Thank you.
Anybody else have any questions?
I have a couple. And this is something I failed to ask, I guess, with North Memorial, but just to understand the cost of service to the patient or to the person that you're seeing. One of the difficulties trying to make comparison about services. We're lucky that we have 2 providers that are here talking to us. But how do we ascertain what the difference in cost to the patient is between services that come to us?
Like a base. Like a base?
Well, or maybe there isn't a way. Maybe there isn't a way that we can say that you in rural New Prague, you can expect to pay XYZ with this company and this XYZ for this company.
We annually, we do a rate comparison, and when we do a rate comparison, we can't legally do a rate comparison with our neighbors, because that would be rate fixing. That's illegal. And so what we have to do is we do a rate comparison with services our size, serving geographic locations like ourselves across a region. And so what we do is we try to determine where our rates are and look at where we position ourselves with other services. And we find ourselves, when we do those surveys, we find ourselves to be right in line with where everyone else is. Are our rates exactly like North's? I'm guessing not. I can't confirm that. However, there's some things that you do need to consider, and that's, first of all,
About 70% of our population that we serve, and I don't know what the geographic numbers are here, but about 70% of the patients that we take care of system-wide are government payers. So that's Medicare, medical assistance, VA, other government programs. And so we can build those patients as much as we could imagine, but we're only going to get paid what the government's going to pay us. So every provider is going to get paid the same.
Does that
And
also
the
happen?
patient isn't
Sorry to
responsible for
interrupt.
that. I'm sorry.
I interrupted you, I apologize. Does that also the same with insurance companies? So XYZ Insurance Company, you're considered a network provider.
Yes.
And so there's a contract that then determines what your
Yeah, if-
reimbursement rate is. Okay.
Yes, if we are a network provider, then yes, we've agreed to accept what the insurance company has proposed to us as payment in full.
So again, you could bill $10,000, but you're only going to get paid $1,000.
What the insurance company is
Because of
going
the
to pay us,
contract,
correct,
right?
yes.
If I could add to that as well, that the government pays us what they pay us, but we cannot balance bill patients. So
yeah.
just to be clear, there's no balance billing on government-paid patients. With insurers, we work directly with the insurer on behalf of the patient to maximize, minimize the risk to the patient on any out-of-pocket that they may incur with that.
The only balance billing that we can do is, for example, Medicare will allow, for example, if they allow $100, they pay 80% of what they allow. And so they'll pay $80. We can balance bill for $20.
Right, because it's still
It's
the
within their
maximum,
allowance,
yes.
yes.
The level of, or staffing model seems to be a little more than what I expected, if I understand this correctly. And what I'm understanding this to be is that the 7 to 7 and 7 p.m. to 7 a.m. are full ALS, and plus an additional full ALS of 10 to 10. Am I reading that correctly then?
You are correct, yes.
So then, and then the fourth is on call, which would not necessarily be ALS. It could be something less. So it seems like.
I think the fourth was the overnight.
Yeah.
Yeah, it's the on-call.
On-call
overnight.
overnight.
It's the
Right, so
second-
that's not ALS. That could be, it could be ALS, could not be.
Correct.
But as I understand it, then it would seem that you need more paramedics to have that kind of a schedule.
We can staff with 1 paramedic, 1 EMT to be an ALS crew.
But how many paramedics would you feel you would have on this type of a model?
Ideal staffing mix would be about 60% paramedics and about 40% EMTs. If we had a mix there, it's a little bit easier to recruit EMTs right now than it is paramedics, but that would be the ideal mix so that we would always have coverage to maximize the ALS staffing model.
Well, I'm not sure I just understood what you just said. So that would mean up to like 8 paramedics?
So if we had 18, I think the staffing proposal was 16 to 18 staff.
Right.
So if we had 18 staff, we'd probably want 12 paramedics.
12, yeah. Okay.
And our ambulances may be staffed with 1 paramedic and an EMT.
Yeah.
And it would still qualify as ALS level.
A crew configuration would be that.
Correct, sorry.
Okay. And then some of the services that you mentioned there, it seemed that there's a lot more being talked about as far as the service level that's being provided than the typical, or at least what we look at historically. Are those just in the community paramedic program, or are they typical EMS things that we would see in New Prague? Some of those additional services?
To begin with, our proposal is to provide the 911 and interfacility transport service.
Okay.
Eventually, as our Et3 program continues to widen out, we hope to be able to bring that here. There's a couple of things, though, with the Et3 program. One of the components to that is to have an alternate transport destination. So, for example, in some of our larger communities, we might have a standalone urgent care center that we could transport someone to versus a hospital.
or a detox center that we could transport someone to versus a hospital. If we don't have those facilities here, that limits us in that ET3 category. We do, though, have capabilities to link to a telehealth physician. So some of those components may eventually get out here. We're in the infancies of this of the ET3 program right now. We've only been at it for just over a year. And so today we're in Rochester. We just expanded to Mankato, soon to start in St. Cloud. And so we're just starting to build the program out, and it's growing pains. And so it takes a little while to get our feet underneath us. So that's the ET3 program. Community paramedic program, that's something we work directly with the practice on. If there's a problem, if there's a systemic problem that they're having at the practice that we feel a community paramedic program could help benefit the practice, then we'll work with the practice to help reduce that problem. In one of our communities that we have today, they had a systemic program where they saw frequent visitors to the emergency department. And so we implemented this community paramedic program to target those patients. And so we went out, and instead of them coming to the hospital so many times a month, we went to them. Did assessments with them, visited with them, made sure they're taking their medications, and all of a sudden their health improved and the ER visits went down. And the providers were happy. The patients were happy. So.
And just to piggyback on my understanding of that, then mental health and like suicide issues and things like that, that isn't part of your normal EMS.
Not today.
You don't have resources in EMS really to deal with that.
Today we have a program that's just starting in Rochester where we have a community paramedic that responds to behavioral health calls with law enforcement. It's not happening, excuse me, it's not happening all the time, but it's happening so many hours per week where they will co-respond with law enforcement and an ambulance won't be dispatched, not immediately. To help with the stigma that an ambulance isn't needed necessarily to transport a behavioral health patient all the time. And so this has been very successful in other parts of the country, and we're just starting to kind of ease our way into that in the Rochester area. Today, our behavioral health transports that we do are, we do the interfacility work, where we do transport behavioral health patients that do need an ambulance transport between, for example, New Prague, and it might be to the Twin Cities, it might be to a center that it might be as far away as Fargo, North Dakota, which unfortunately isn't uncommon.
Yeah.
Thank you.
Any other questions?
Time's up.
Okay, we've hit the time limit, so now what we're gonna do is we'll consider the two options. We're gonna talk about it at the next council meeting, and I would assume that if any council members have any questions, they can filter them through Josh. Josh will get them to the appropriate, because you know what, there's gonna be something that's gonna come up, so.
Correct.
And we'll make our decision at the next council meeting, which is in 2 weeks, right?
April 18th.
April 18th, so. Thank you for coming.
Thank you.
Thank you, guys. Appreciate it.
Yeah. Given the lateness of the
Yes.
evening, so thank you.
Drive safe.
Thank you.
Yep.
Do we have to adjourn out of this one, or?
Yep. I will take a motion to adjourn.
Moved.
I'll second.
I just want to clarify how we're treating this communication. We're going to, if we have follow-up questions, we should direct them to Josh.
Send them to me, and I will get in contact with.
And then there's
whoever I need to.
two other issues that I was
Thank
wondering. Do we want references to be called? And then have we checked for any complaints with state emergency medical place?
I
think we did that last
I can
time.
call references if you like. I have not checked on complaints yet, but I definitely can do that.
But the complaints, I think, is a simple thing. I guess I'd rather you do it than us do it. And I don't know how you ask about that, because I don't know if you do it by name of employee or how that works.
I have been texting with the ambulance director down in Dodge Center as people have been talking to vet information, so I can just ask her how I can get a hold of that stuff.
Yeah, there's a state board.
Yeah,
I just
there's
not sure if
the
they-
state EMSRB board, correct.
And they keep track of each individual person, which I don't know if we wanna ask that question, but.
No, I mean, I think I'd more look at just kind of general, are they seeing a lot of complaints, or like, how does the complaints compare size-wise? I mean, I'm sure I can flesh it out.
I don't think there was any complaints at all last time from either, but just to verify that.
They did do that? You did do that the last
I think we made the phone call anyway.
Okay.
And references, I don't have a particular opinion about that, whether we need to do that or not, but I just wanted to bring up the issue in case someone feels we need to.
No,
To answer your question, she said response times are pretty normal to be around 8 minutes. For like in-town stuff and rural stuff, stretches usually somewhere between 12 and 14, and she wouldn't be surprised.
Steve, what is yours?
Memorial's exactly the same.
Your response time?
Well,
I'm
they
saying
had
3
their,
minutes.
they had their data in their proposal.
I know, you're there before the cops. I'm saying 3 minutes. Takes you 3 minutes to get down to the apartment.
That's where it is. If we're going, we cover all the way out to Jordan's Tavern,
Mm-hmm.
so it's not 3 minutes out there.
No.
But if we're going to Mill Pond from my house, it's probably 2.
That's why you're there all the time? You gonna move in there? You want a room?
Here all the time for fun.
Okay,
That's the only questions I have.
okay. There's a motion to adjourn. Is there a second?
Yes, a second.
Okay. All in favor, say aye.
Aye.
Adjourn. Thank you, everybody.
Thank you. Thank you, Josh.
So I put Joshua on everything because it doesn't sound like I'm the president of a frat at Arizona State. But I usually play Josh.
Thank you.
So either one works.